Still the audience want me to listen.
And it will be followed by lunch. For hands-on we have 4D from Medisone, they have brought it. But I don't think in small parts we can use it, we don't have experience. If we get a chance for Professor Safdar Ali Malik, he can help us. And we congratulate him that he is the pioneer in 4D in Pakistan. And he has started, he has got that. And hopefully he will be starting 4D on musculoskeletal also, and we will get some nice images on musculoskeletal. So we can try on that if you give us a chance.
Is it? So, anybody is doing the cranial ultrasound?
Yes.
That's good. So do you find any, you can say, ease of operation and information, what you feel is convenient? Actually, what happens, we found that ultrasound, cranial ultrasound, what we are doing it in now is picking up very fast in our day-to-day practice. Why? Because most of the time it is required to do on sick babies which are really sick, and they cannot be easily transported to the CT room or to MRI room. That's why the portability of ultrasound has made it an excellent imaging tool for evaluating the infant brain. Previously it was not getting proper attention, ultrasound imaging was not getting the proper attention by the neonatal unit. But the amount of information what we are getting and the ease of operation without dislodging these sick babies from the ventilators or in neonatal unit, it has become an integral part of neonatal unit, mainly the high risk pregnancy care unit, and it has replaced CT scan to evaluate normal brain, not because ease of operation and amount of information we get it. Excellent resolution of the brain parenchyma and the ventricles and the meningeal space. And the biggest advantage, or what you can see, the anatomy is almost similar to the MRI what we get on MRI. This is an MRI image and this is an ultrasound image. What we are getting, you can see the excellent tissue details. These are ventricles, frontal horn, third ventricle, frontal horn, interhemispheric fissure, temporal lobe. This is a coronal view, this is also the coronal view, and then we can get the sulci and gyri. We are getting the sulci and gyri. These are the temporal lobes, and these are the transorbital bone of the frontal ridge of the orbital ridges of the frontal bone. So these are the air in the nasion, what we are getting it here. So the anatomy and the information is similar what we get on ultrasound is similar to the MRI. Then what are the advantage? The advantage that we don't need any sedation. That is the biggest advantage. It can be done at bedside on the even the ventilator without dislodging the infant. Periodic follow is very easy as far as the evaluation is concerned. We don't need any contrast injection for highlighting the vessels or something, and we can do the guided procedures, ultrasound guided procedures, and of course the cost of the investigation in terms of MRI and CT is very low. What we just know, because we know in the body there are 2-3 things which are not very good conducting medium to the sound beams, and bone is one that, bone, air and all those things. So we need a window, and unfortunately in infants or in neonates or in that we need a window to look into the brain, and that is from the anterior fontanelle and at times the frontal or occipital or posterior fontanelle. Like this is a diagram which shows you how we can see from the anterior fontanelle in a coronal section. Primary framework is through the ventricular system, and by rocking movement of the transducer, this way we can map whole of the brain. By rocking this way we can map whole of the brain. We can see this is the coronal section and this is the coronal section, which is seen diagrammatically. What we are seeing, these are the thalami, this is the temporal horn, this is the fox, and this is the third ventricle, these are the frontal horn of the lateral ventricle. All this thing we can see. We need a 5 and 7.5 megas probe short focus sector scanning. Here we need sector probe. We don't need any linear probe because we have a small opening, which it should have a high fan beam, like going like this. So we need a sector short focus for window anterior and posterior frontal craniotomy at times in adults, and perioperative ultrasound we are also doing in our neonatal in neurosurgery. We are doing it. So we need craniotomy in adults, and second, we don't need any sedation. Like this, again technique. This is the coronal view, and this is the parasagittal view. Again, the framework is the normal anatomy is around the ventricular system, and this is the rocking movement through the anterior foramen in coronal section, which is showing you, and this is the rocking movement, to and fro movements in the anterior fontanelle in parasagittal view, right and left both. This is the left, this is the right, this is the left, this is the right. This is the coronal view on both sides. You can see here, this is again, I tell you, this is the frontal horns, this is the cavum septum pellucidum, and this is the third ventricle. This is air which is seen in the nose. These are the temporal horn, and this is the, again you can see the air here, and this is the orbital ridges. So this is also known as transorbital view. This is the right and left parasagittal view, where we can see the high parietal lobe. We are seeing the sulci and gyri. We are seeing the cavum septum pellucidum. This is the thalamus here. This is the fourth ventricle here, which is seen here. This is the left and this is the right. So all this thing we can see on ultrasound. And if you have a color Doppler, we can see the vascular anatomy also. This is the normal, and then this is the axial view, which shows you the choroid plexus in the ventricles, lateral, these are the lateral ventricles, and these highly echogenic things are nothing but these are the choroid plexus, and this is the posterior horn or posterior lobe, which is showing you part of the vermis over there. So this is the axial view, this is the sagittal view, and three planes, one axial, one sagittal or parasagittal, and one is coronal or transorbital. And this is the vascular anatomy. It shows you, this is the vein of Galen, which is coming here, and these are the vessels which are feeding. This is the middle cerebral artery, and these are the branches, and this is the vessels which are showing you feeding the parietal lobe. Then again we can see here the spectral Doppler tracing. This is the vein of Galen, which shows you the venous flow. This is the superior sagittal sinus. Here you can see here, if any subdural hemorrhage is there, we can see this is running in the subdural space, and this is the high parietal cut, which shows you superior sagittal sinus here, SSV, showing the vein here, and these are the arteries, lenticulostriate arteries coming out from the middle cerebral artery, which is showing you supplying the thalami. How beautifully they are picked up on high resolution ultrasound. So all this thing we can see, lenticulostriate arteries coming out from the middle. This is the Sylvian fissure, and this is a part of the middle cerebral artery. These are the branches which are going radial fashion and supplying the thalamus. Again, this is the axial view, which shows you the vein of Galen, which is here, and here part of the anterior cerebral artery which is coming here, and these are the thalami, and this is a part of the vermix and the posterior fossa which is seen over here. So all this thing we can see, vascular anatomy, we can see the cranial anatomy without putting any contrast and this thing. Then what are the This again I am telling you how the images are comparable to MRI, well illustrated anatomy, and the primary framework is around the ventricular system that I already told you. Now normal three views which are second, coronal, parasagittal and axial planes. Then what are the indications for neurosonography? The indications are the congenital malformations, premature infants, intraventricular hemorrhage, infections, birth asphyxia, hydrocephalus, and of course neoplasm, which are rare entities. Then coming to the situation like congenital anomalies, where we can see here the agenesis of corpus callosum. The ventricles are parallelly placed. They are seen, there is no frontal horns are also, if they are rudimentary or they are not seen, and of lichencephaly, where we can see the absence of the sulci and gyri and agenesis of corpus callosum, plus tear-shaped ventricles, and this is the CT scan which also shows you the same thing, the parallelly placed ventricles, absence of sulci and gyri, and this is ultrasound, and this is the CT scan. So all these things we can see in lichencephaly or agenesis of corpus callosum. This is the features, and what it could be in a pregnancy, whether it's a dilated ventricle, or this is a cyst, arachnoid cyst, or this is something neoplasm. But as soon as you put a color, immediately you see this is nothing but aneurysm of vein of Galen. This is a pregnancy in a patient who was having just for the scanning, came at a 35 weeks plus pregnancy, and when you put a spectral Doppler, you see and there is a high bizarre flow seen in this aneurysm of vein of Galen. And then when the patient was born, you can see here this is a hypoechoic, a low level echo complex mass which is seen here, maybe thought to be a case of dilated ventricles, but when you put a color, you see immediately this is nothing but aneurysm of vein of Galen, and this is the feeding vessel, and this is the big aneurysm. So all these things you clinch in one stroke with the proper equipment and the proper technique. Then meningitis, the brain infection. Ultrasound doesn't tell about the problem, means diagnosis, but it tells about the sequelae, what is the complication which are. Diagnosis is done by the basic lumbar puncture, whether this is a pyogenic meningitis or this is a tubercular meningitis or this is something else. But what it leads to, how it is going to affect, and what are the complications, there ultrasound plays a major role. So primary investigation in meningitis is nothing. It means neither CT scan nor MRI that tell about the primary infection. It is only by lumbar puncture. So primary investigation is by lumbar puncture, HRSG to study the sequelae like hydrocephalus, ventriculitis, and all these things. So this is a small abscess which is seen in the brain. In a case of cranial infection, this is an abscess and this is another abscess. This is parathalamic abscess, this is a thalamus, and this is a big abscess. You can see here a big abscess seen in the right parietal lobe, having the mass effect and pushing the ventricles, obstructing the third ventricle, resulting into the hydrocephalus, and this is a big abscess which is seen here in the parietal lobe. Again, this the abscess or infection or meningitis leading to the basal arachnoiditis, and that basal arachnoiditis result into the obstruction in the flow, resulting into the obstructive hydrocephalus. And these are the strands which are seen floating from the ventricular wall, showing this is also associated with ventriculitis. So there is a hydrocephalus, dilated fourth ventricle, dilated temporal horn, dilated third ventricle, dilated frontal horn, and these are the ventricles, lateral ventricles, and these are the choroid plexus, and these are the strands. Highly echogenic walls of the ventricles with thickened wall with